Welcome to this new episode. Today we're diving deep into pediatric respiratory infections, a topic that's deceptively complex given the overlapping anatomy and the many factors influencing disease presentation and management in children.
Yeah, it's fascinating how these infections, while common, really challenge us because they rarely stay confined to one part of the respiratory tract. The mucous membranes lining the entire tract are contiguous, so infections often spread, making diagnosis and treatment a bit of a moving target.
Exactly. And when we talk about respiratory infections in kids, we have to keep in mind the anatomical distinctions between the upper and lower respiratory tracts, plus the concept of croup syndromes, which involve the larynx and adjacent structures. It's a lot to unpack.
Absolutely. So let's start with the basics of anatomy and classification. Respiratory infections are categorized based on the anatomical area involved. The upper respiratory tract includes the oronasopharynx, pharynx, larynx, and the upper part of the trachea.
Right, and the lower respiratory tract comprises the lower trachea, main stem bronchi, segmental and subsegmental bronchioles, terminal bronchioles, and alveoli. But what's important is that infections rarely respect these boundaries.
That's a key point. Because the mucous membrane lining is continuous, infections often involve multiple areas simultaneously, even if one area predominates clinically. This explains why symptoms can be mixed, and why management needs to consider the entire respiratory tract.
And that brings us to croup syndromes, which are infections primarily involving the trachea, epiglottis, and larynx. These can overlap with lower airway involvement, but the laryngeal symptoms often dominate the clinical picture.
Exactly. And understanding this anatomical overlap is crucial because it influences both the clinical presentation and the urgency of intervention, especially in young children with smaller airways.
Speaking of which, let's talk about etiology and characteristics. Respiratory infections in children are predominantly viral. The main viral culprits include respiratory syncytial virus, rhinovirus, non-polio enteroviruses, adenoviruses, parainfluenza viruses, and human metapneumoviruses.
Yes, and bacterial pathogens come into play either as primary invaders or secondary infections. These include group A beta hemolytic streptococci, staphylococci, Haemophilus influenzae, Chlamydia trachomatis, Mycoplasma pneumoniae, and pneumococci.
The age of the child really shapes susceptibility. Infants under 3 months have a lower infection rate due to maternal antibodies, but they remain vulnerable to specific infections like pertussis.
Right, and between 3 and 6 months, infection rates increase as maternal antibodies wane and the infant's own immune system is still maturing. Toddlers and preschoolers have high viral infection rates, but by age 5, viral infections decrease while bacterial infections like Mycoplasma and GABHS become more common.
That's an important shift. Plus, as children grow, their lymphoid tissue increases, and repeated exposures build immunity, which explains why older children often have milder illnesses.
Although some pathogens like pertussis can cause mild illness in older children, but severe lower respiratory tract disease or croup in infants. So age-specific responses are critical to consider.
Definitely. Now, anatomically and physiologically, young children are at a disadvantage. Their airways are smaller in diameter, so even minor mucosal edema or secretions can cause significant narrowing.
And the shorter distances between respiratory structures mean infections can spread rapidly down the tract, leading to more extensive involvement.
Plus, the eustachian tube in infants is shorter and more open, which predisposes them to middle ear infections.
Immunologically, passive immunity from maternal antibodies diminishes in early infancy, but breastfeeding prolongs some immune protection through antibodies in breast milk.
And children with immune deficiencies, malnutrition, anemia, or fatigue are at increased risk. Chronic conditions like asthma, cystic fibrosis, bronchopulmonary dysplasia, and cardiac anomalies causing pulmonary congestion also predispose to infections.
Environmental factors matter too. Daycare attendance and exposure to secondhand smoke increase infection risk.
Seasonality plays a role as well. Most respiratory pathogens peak in winter and spring, with mycoplasma infections more common in autumn and early winter. RSV seasons typically span winter and spring.
That seasonal pattern is something clinicians always keep in mind when evaluating respiratory symptoms.
Moving on to clinical manifestations, infants and young children, especially those between 6 months and 3 years, tend to react more severely to respiratory infections.
They often present with generalized signs like fever, irritability, poor feeding, vomiting, diarrhea, and abdominal pain. Fever can be absent in neonates, but tends to be high in toddlers, sometimes reaching 40.5 degrees Celsius.
And that high fever can precipitate febrile seizures in susceptible families, which is a significant concern.
Local signs depend on the site of infection: nasal congestion and discharge, cough that can be dry or productive, hoarseness, stridor, and wheezing.
Respiratory distress signs include nasal flaring, intercostal and substernal retractions, grunting, head bobbing, and cyanosis.
Meningismus, or meningeal signs without meningitis, can also occur with abrupt fever onset, which can complicate the clinical picture.
Hydration status, activity level, and comfort are important to monitor closely.
Absolutely. Now, when assessing respiratory function, a comprehensive approach is essential.
That includes evaluating respiratory rate, depth, rhythm, and effort. We look for tachypnea or bradypnea, shallow or deep breathing, and signs of labored breathing, like retractions, nasal flaring, and head bobbing.
Auscultation findings are critical. Wheezing, crackles, or absence of breath sounds can guide diagnosis.
Cough characteristics matter too: timing, nature, triggers, and whether it's dry, moist, or brassy.
Presence of stridor is a red flag for upper airway obstruction.
Pulse oximetry is a non-invasive way to assess oxygen saturation and should be routine.
We also look for signs of infection like fever, lymphadenopathy, mucosal inflammation, and purulent discharges.
Hydration assessment includes checking urine output and mucous membranes.
And don't forget other symptoms like abdominal or chest pain and halitosis, which can provide clues.
Vigilant monitoring for signs of respiratory failure is paramount.
That's where nursing care principles come in. Easing respiratory effort is often the first step.
Most infections are mild and can be managed at home. Warm or cool mist can soothe inflamed mucosa, but hot steam vaporizers are discouraged due to burn risk.
Shower steam is a safer alternative, running hot water in a closed bathroom to create humidified air.
Maintaining a calm environment helps reduce distress-induced respiratory effort.
Promoting rest and comfort is also key. Encourage rest or quiet play, and for infants, nasal suctioning with saline drops before feeding and sleep can help clear passages.
Over-the-counter medicated nose drops, sprays, and cough medications should be avoided in children under 6 without medical advice.
Infection control measures include hand hygiene, cough etiquette, avoiding sharing utensils, and keeping sick children out of school or daycare.
Temperature control involves educating parents on accurate measurement and appropriate use of acetaminophen or ibuprofen, with caution about combination cold meds to avoid acetaminophen overdose.
Hydration is critical, especially in febrile or vomiting children. Small, frequent fluids are best, and breastfeeding should continue.
Avoid caffeine-containing fluids and sports drinks in young children.
Nutrition-wise, children should self-regulate intake. Forcing food can cause aversion.
Family support is essential. Education on medication adherence, symptom monitoring, and when to seek care.
And, importantly, warn against unprescribed antibiotics to prevent resistance.
Now let's get into specific infections, starting with nasopharyngitis and pharyngitis.
Nasopharyngitis is essentially the common cold, caused by rhinovirus, RSV, adenovirus, enterovirus, influenza, and parainfluenza.
Symptoms tend to be more severe in infants, with fever common in young children.
Pharyngitis can be viral or bacterial, with group A beta hemolytic streptococci as the main bacterial cause.
Clinically, nasopharyngitis presents with nasal congestion, sneezing, cough, irritability, and poor feeding.
Pharyngitis features sore throat, fever, headache, abdominal pain, and sometimes tonsillar exudate.
Treatment is supportive: antipyretics, rest, hydration.
Cough suppressants containing dextromethorphan should be used cautiously due to potential adverse effects like confusion and sedation.
Antihistamines and expectorants are generally ineffective.
Antibiotics are reserved for confirmed bacterial infections.
Prevention focuses on avoiding contact with infected individuals and educating parents on signs of complications like breathing difficulty or persistent fever.
Moving to acute streptococcal pharyngitis, caused by GABHS, It carries risks of rheumatic fever and acute glomerulonephritis.
The onset is abrupt with sore throat, fever, headache, and abdominal pain.
Physical signs include tonsillar exudate, strawberry tongue, and tender cervical lymphadenopathy.
Diagnosis relies on rapid antigen detection tests, with throat culture if suspicion remains despite a negative rapid test.
Testing should be avoided if viral symptoms like rhinorrhea or cough are present, to prevent unnecessary antibiotics.
Treatment is oral penicillin for 10 days to prevent rheumatic fever.
Alternatives for penicillin allergy include erythromycin, azithromycin, and cephalosporins.
Nursing care involves educating on medication adherence, symptom relief with analgesics and warm gargles, and preventing spread by discarding toothbrushes after 24 hours of antibiotics.
Parents should also avoid sharing utensils and monitor for complications or treatment failure.
On to tonsillitis and surgical interventions. Tonsils are lymphoid tissue protecting the respiratory and alimentary tracts.
Tonsillitis often accompanies pharyngitis and can be viral or bacterial.
Enlarged tonsils may obstruct the airway or swallowing.
Indications for tonsillectomy include recurrent peritonsillar abscesses, obstructive sleep apnea, and significant airway obstruction.
Adenoidectomy is recommended for hypertrophied adenoids causing nasal obstruction or recurrent infections.
Postoperative care includes positioning to facilitate drainage, avoiding suctioning unless necessary, and pain management with acetaminophen and ibuprofen preferred over opioids.
Monitoring for hemorrhage is critical. Watch for frequent swallowing, vomiting bright red blood, and tachycardia.
Diet should be soft and non-irritating, avoiding citrus and milk products initially.
Activity restriction helps prevent bleeding.
Safety alerts include contraindication of codeine under 12 years and close monitoring for respiratory distress in children with sleep-disordered breathing.
Influenza is next. It's caused by orthomyxoviruses types A and B, which cause epidemics, and type C, which causes milder disease.
Transmission is via droplets and contaminated surfaces.
Hospitalization rates are highest in children under 5.
Risk factors for severe disease include indigenous status, chronic illness, poverty, and overcrowding.
Clinical features include sudden fever, chills, myalgia, dry cough, and hoarseness.
Subglottal croup is common in infants.
Complications include viral pneumonia, encephalitis, and secondary bacterial infections.
Treatment is supportive with antipyretics and hydration.
Neuraminidase inhibitors like zanamivir and oseltamivir are effective if started within 48 hours.
Zanamivir is inhaled and contraindicated under 7 years and in asthma.
Vaccination is recommended annually for all children over 6 months, with quadrivalent vaccines preferred.
Special considerations apply for high-risk groups and contraindications.
Nursing care focuses on symptom relief, monitoring for secondary infections, and educating on vaccination and infection control.
Otitis media is inflammation and fluid in the middle ear, common in early childhood.
It often follows viral respiratory infections like RSV and influenza.
Risk factors include passive smoke exposure, daycare, bottle feeding lying down, allergies, and anatomical abnormalities.
Pathophysiology involves eustachian tube dysfunction leading to fluid accumulation and infection.
Diagnosis uses pneumatic otoscopy to assess tympanic membrane mobility.
Acute otitis media shows bulging, red, immobile membrane with acute symptoms.
Otitis media with effusion has fluid without acute infection signs.
Treatment emphasizes judicious antibiotic use to prevent resistance.
Antibiotics are reserved for severe symptoms or young infants.
Amoxicillin is first line. Alternatives for allergies include cefuroxime and ceftriaxone.
Myringotomy or tympanostomy tubes may be needed for recurrent or chronic cases.
Nursing care includes pain management with acetaminophen or ibuprofen, ear hygiene if drainage is present, and educating parents on medication adherence and prevention.
Hearing assessment is important for persistent effusions.
Infectious mononucleosis is caused by Epstein-Barr virus, common in people under 25.
Transmission is via saliva, and symptoms include fever, exudative pharyngitis, lymphadenopathy, and hepatosplenomegaly.
Diagnosis uses heterophil antibody tests like the monospot.
Treatment is supportive. Antibiotics are contraindicated unless bacterial superinfection is present.
Corticosteroids are reserved for severe complications.
Nursing care focuses on symptom relief, activity restriction, especially avoiding contact sports if splenomegaly is present, and monitoring airway for edema.
Safety alerts include seeking urgent care if severe throat pain, breathing difficulty, or abdominal pain develop.
Finally, croup syndromes, a group of acute infections causing barky cough, hoarseness, inspiratory stridor, and respiratory distress.
These include acute epiglottitis, laryngotracheobronchitis, or LTB, acute spasmodic laryngitis, and bacterial tracheitis.
Acute epiglottitis is a medical emergency, mainly in children 2 to 5 years old, caused by Haemophilus influenzae type B.
The child assumes a tripod position, drools, has a muffled voice, and high fever.
Throat exam should be avoided unless airway equipment is ready.
Treatment involves airway protection, IV antibiotics, and humidified oxygen.
LTB is the most common croup syndrome, viral in origin, with gradual onset of barky cough, stridor, and hoarseness.
Treatment includes oral corticosteroids like dexamethasone and nebulized epinephrine for severe cases.
Monitoring for respiratory distress and educating parents on warning signs is essential.
Acute spasmodic laryngitis features sudden nighttime episodes with mild inflammation and is managed similarly to LTB.
Bacterial tracheitis is a severe infection, often post-viral, with high fever, toxic appearance, and thick purulent secretions.
It requires antibiotics and sometimes intubation.
Nursing care involves continuous respiratory monitoring, supportive care with oxygen and hydration, parental reassurance, and early recognition of airway obstruction.
To wrap up, pediatric respiratory infections are complex, influenced by age, anatomy, immune status, and environment.
Balancing avoidance of unnecessary antibiotics with timely treatment of bacterial infections is critical.
Nursing care plays a vital role in symptom management, hydration, infection control, and family education.
And safety alerts, especially regarding epiglottitis and post-tonsillectomy hemorrhage, must always be top of mind.
Prevention through vaccination and environmental controls remains key to reducing the burden of these infections.
Thanks for joining us in this detailed exploration. Hopefully, this deep dive helps clarify the nuances and complexities behind what might seem like everyday illnesses.
Absolutely. Until next time,